to Rural Health Everywhere. I'm your host, Danielle Renckly. Today, we're diving into physician compensation and contractual matters. Going in, I didn't understand why something that seemed relatively simple, how much you pay your providers, was so important to how a rural hospital operates. Luckily, I had two experienced attorneys from Krieg DeVault who were willing to sit down with me for a conversation. Senior counsel Maggie Little and partner Brian Heaton both have considerable experience when it comes to rural health. I'll let them explain.
So I've been practicing for almost 10 years. This fall, I started my career here at Krieg DeVault back in 2016. I left after a couple years and joined a large health system in their in-house legal counsel department. Spent almost 7 years there working primarily with the provider medical group with all things contracting, employment, compensation related, specifically supported physician compensation policies and compliance committees, and spent a lot of time with the actual physician compensation and finance department as well. I rejoined Krieg DeVault here in January, so I've been back with Krieg for about 3-4 months now and spending a lot of time with our hospital clients.
So I've spent my entire legal career at Krieg DeVault. I'm a contract healthcare nerd at heart. I've been lucky enough to work with our hospital and physician clients throughout my entire career. I was a finance undergrad and went to IU for both my AD but also my MBA. So really enjoy working on financial and contractual matters for our healthcare clients and digging into that. And so I think it ties in well with what we're going to talk about today.
Yeah, so today we're going to spend some time talking about physician compensation and contracting matters and why these matter so much to the operations of rural hospitals. So I know you both have a lot of expertise here, like you just said, so I'm really looking forward to hearing from you both on this. I think it's going to be a great conversation. But first, I want to talk about rural compensation. Let's start with that. So I feel like that looks different a lot of the time than you might expect. So to start off, can you explain a bit about why our rural hospitals are paying higher physician salaries than the traditional benchmark suggests they should be?
So I think when you look at supply and demand, there's a lot fewer physicians who are looking to practice in a rural setting. There's more pipeline that would stay in necessarily a larger city. And to be able to recruit and retain talent, a lot of times rural providers have had to offer a higher payment to those physicians. Also, when you look at traditional metrics around paying people based on production, there may not be as much demand for those specific services. And so paying a physician based on necessarily the volume that they have doesn't always align with what their value is. And you may have services, and rural hospitals absolutely have services that they need to be able to serve their patients and their communities, regardless of whether it's something that is a high volume or not. So there's a balancing higher wire act that our hospital providers have to walk to be able to pay a fair amount to the physicians while also kind of meeting those dynamics.
Yeah, and I'll just add to that, Brian. I think a lot of times when we're talking about our rural healthcare partners, we're looking to really make sure that we preserve access to certain specialties and services in those areas. So a lot of times that can be a new factor that maybe some of the metropolitan areas don't have to think about as often because of the sheer amount of providers and the competition there. So I think that's something that really comes up a lot with the rural healthcare providers is making sure that they're maintaining access for the community to certain services so that patients can stay in their community to get these services. And when we talk about this compensation, these components tied with it, just because we're talking about a rural health setting and because maybe there's a higher need or because it is a community need or there's a need for access or things like that, that doesn't mean that we can essentially avoid the compliance safeguards and the regulatory requirements tied to physician compensation. As we all know, physician compensation is very heavily and highly regulated by the government. We have to be sure that we're paying our physicians essentially following under two standards, and we want to make sure that we pay them fair market value and that it's in a commercially reasonable manner. And that's to make sure that we comply with the Stark Law and the anti-kickback statute.
A quick and probably too simple explanation on Stark laws for those who might not know. This is a federal rule that prevents doctors from sending patients to healthcare services or facilities where the doctor or their family could financially benefit, unless certain exceptions are met. The goal is to reduce conflicts of interest and make sure medical decisions are based on patient needs rather than profit. It's mainly going to apply to services paid for by Medicare and Medicaid, and it's important for healthcare organizations to follow so they can avoid penalties.
So really the key component here is we want to make sure when we're setting up these compensation arrangements that are kind of considered outliers and maybe look a little bit different from the metropolitan partners, making sure that we're documenting these arrangements in a way that makes sense and that can really justify the need for those services.
I was curious to know about what regulators look for when they're reviewing compensation. Brian had this to say.
So there's different aspects of compensation. And like Maggie said, you have to consider what's fair market value. And there's fair market value studies out there that can tell you what benchmarks are depending on production and where you're located. And any kind of a compensation consultant, we have a lot of clients that work with compensation consultants that come in and offer opinions on fair market value and things like that. So that kind of feels a little easier. Where we see more dynamics that are challenging are on the commercial reasonableness side and also compensation stacking. So commercial reasonableness goes more toward, even if a payment is necessarily fair market value, did it make sense and was it commercially reasonable to enter into that contract with that physician? Do you need that service? Do those duties that the physician's providing make operational sense? And do you need to, even if you're paying a physician an hourly rate for medical director services that is fair market value, are you assuming that they're spending 20 hours a week as a medical director when they have so many other things that they're doing as well? As just one example. The other thing is the compensation stacking arrangement. A lot of times with physicians in a rural setting, they're wearing a lot of hats. They have to. There's fewer physicians, and the government assumes that everyone's a criminal. And a lot of the times our clients and these physicians, they're really trying to do the right thing. And it's an all hands on deck mentality to make sure patients are taken care of, and it's noble. But it's just like any other rule in life. A few people ruin it for everybody else. And so if you have a physician who's getting paid to see patients and they have compensation for that, just their regular fee for service type things they do, but then they also get a stipend for supervision of nurse practitioners and PAs, and then they also have an additional payment for being a medical director, and then they also get an additional payment for something else. It starts to add up in a way where the overall compensation is challenging, and the regulators will come in and say, you may have been fine with each individual portion of that compensation, but the overall amount has gotten to a point where it's too high. So Maggie, I don't know if you have anything to add to that, but those are a couple of things we see a lot for regulators to come in and look at.
Yeah, and I think just touching on some ways that I think our health system partners can focus on making sure that they're documenting things appropriately to justify these things for regulators. So if a regulator comes in and wants to know, well, why did you pay this physician at the 75th percentile when they produce, or they're projected to produce at the 20th percentile? Some things that often we would recommend that are documented and are kept by the system, whether with that physician's employment file or in accordance with their contracting policy, making sure documenting what's the need for that service. As Brian said, again, we want to make sure that things are commercially reasonable. So even if you're going to pay a fair market value rate, is there a true business need? So that need could look like, again, making sure that a certain specialty remains available to the patients of the community. The other things we want to look at sometimes too are how hard is it to recruit this position? So how long has this position been vacant? How many offers have been made to certain physicians? How many have been declined? Do you have data on counter offers that were made? Things like that can really help support that position of, we're going to pay at a higher rate, but here's why, because this has become a hard to recruit position, and this is what we need to do to get somebody in the door. Some other things to think about, again, focusing on access, are what's the median lag for that specialty for appointment times and getting in to be seen by a specialist, or even just in a family medicine setting. Are there enough available providers in the community? How many other providers of a specialty are available to see patients, whether it's in the system or just otherwise outside of the same system? So we want to make sure that those things are getting documented. And I think that's what one of our themes here throughout this is. We're not saying that you can't come up with great, unique, and creative solutions to attract providers to the area and pay them in a creative way that keeps a rural health system competitive with maybe the metropolitan systems, but also making sure, though, that those arrangements still stay compliant and check those boxes that we need to check from a fair market value and commercially reasonableness standard. In terms of compensation stacking, I think I completely follow Brian's points here. I think a lot of times where we get into trouble too is seeing folks that say, yeah, I'm going to spend, technically my whole FTE may add up to a 1.2 by the time we add everything in, but are you really performing the services as a 1.2? And then I think we start to worry a little bit about quality of services as well once we get into those situations. If somebody's supposed to be providing services of a 1.0 in a clinical setting and then another 0.2 in a medical director setting, at some point you start to wonder what's going to give. There's only so many hours in a day. And that leads to, I think, some questions too. While these aren't necessarily compliance or regulatory concerns, but we all know that physician burnout is a real thing and is something that especially I'm sure our rural providers are dealing with. Yeah, another just area to really stay in check and make sure that we've got strong documentation on that compensation stacking piece as well, documenting specifically what those clinical duties are. Is there a way to track productivity measures, work RVUs, hours, and then the same thing with the administrative duties, making sure we're tracking those hours and it makes sense, the services that they're actually providing.
But when we're talking about mistakes that are commonly made in our rural hospitals when we're dealing with physician compensation, do you think lack of documentation is the name of the game, or is there something else that's commonly an issue?
I think the documentation is a key one. I think one of the challenges we always have when we get brought in, usually when we get brought in to review this, we're either talking about designing a new plan for how the hospital is going to move forward in a more coordinated way. When you have changes in leadership over time, you've got different opinions. The way payers pay hospitals is very different now than it used to be. There's just all sorts of reasons why hospitals should be looking at how they're paying their providers. And that's, we're talking about physicians a lot, but this applies as well to APPs as well. And they are increasingly important in making sure there's access to care. And a lot of times you wouldn't maybe be able to pay a physician, but you have a really strong APP that can be very valuable. And so these rules can apply as well in terms of what we're looking at for how you pay people. And so I think for me, the hospitals often have to challenge their status quo, because if we're not looking at a new program, or even when we are, there's been relationships with providers that have been there a long time, and they don't want to have difficult conversations because the physician's not necessarily doing anything wrong. They're still doing what they were doing, but the market has evolved in a way that you can't really pay them in the same way or the same amount. And so that's a challenge. And so we have to have really tough conversations, and you have to have leadership that's willing to explain to the providers and have tough conversations about, this is not punitive. This is not because we don't love you. We just want to make sure that this is sustainable for the benefit of the organization and our compliance.
And with APPs, just to make sure that there's anyone who might be coming into this fresh, can you define that?
It's an advanced practice provider. So if we're talking about nurse practitioners, physician's assistants, things like that.
Maggie agreed with Brian when asked. Documentation is one of the most important things you can do to ensure that your hospital is in compliance.
To Brian's point, I think the name of the game and what it all comes back to is that documentation piece. Having those strong safeguards in place, I think, is something we see a lot with hospital clients, is making sure they've got policies, they've got procedures, they've got methods in place to continually track the compensation of the physicians and providers. As Brian said, a lot of times we look at these and there wasn't bad intent. Again, it's just, we've got to get somebody in here to provide these services. This is what we have to do to get them to come, to get them to stay. We have to offer retention bonuses and things like that. But where we get into trouble sometimes is because of that weak documentation system, or not having adequate documentation or policy or checks and balances, those contracts may end and then we continue paying somebody, or the nature of the services changes, the contract, and we never updated the contract. Somebody's now performing at a 0.8 instead of a 0.1, and we never updated the compensation in there. I think, again, that all comes back to having strong documentation and having those strong policies and procedures in place. And I think the other thing, too, to keep in mind is the physician compensation review is truly an ongoing process. We can't just review it when somebody starts and say, okay, we're going to offer them this guaranteed salary and we're good to go. It's really something that should be happening on a regular basis, probably no less than an annual basis, just to make sure, again, does this compensation arrangement still make business sense? Is it commercially reasonable? And is it fair market value? Are we now paying somebody well above thresholds or benchmarks that we're comfortable with? And do we need to take a look at that? Is their productivity out of line with what we're paying them? Do we need to, have a hard conversation to say the volume's not there? This is nothing that you've done, but the volume's not there. We're going to need to make some adjustments here. So I think, again, at the end of the day, it comes back to how are we documenting things? Do we have files? Are we keeping these things tied to the physician's employment file and things like that?
Something I did want to ask about, and this comes from talking to a couple of staffing companies before. So are there compliance risks that are going to come with things like signing bonuses or loan repayment, like stipend program, that kind of thing?
Yeah, absolutely. So again, all of these things, a lot of times we see these as recruitment incentive packages. So we say, if you join us, in addition to this compensation package that we're going to offer you for your services, we're also going to pay you a $50,000 sign-on bonus. So immediately we need to include that amount in the physician's total cash compensation to do that evaluation. So when we're evaluating somebody's compensation from a fair market value and commercially reasonable standpoint, we have to look at everything that's being offered. So that includes, again, signing bonuses. It could be if we're offering relocation assistance, basically anything that's going to get lumped into somebody's W-2 income. If they're employed, that is part of that compensation we need to review. So we're looking at that whole picture there. And then as we start to think about the person is going to start with us, we're ready to pay this signing bonus, but we want to make sure that we've got some teeth tied to it. If they were to leave after a certain period of time, do we want to be able to claw that back? And that can get tricky from a tax perspective. We want to make sure that we're viewing these things appropriately in that setting. But then I know I'm going to let Brian talk a little bit about, I know there's some restrictions around in Indiana now with all of our non-compete restrictions. There's some ways that we need to think about that as well to make sure that we're not using a signing bonus really as a non-compete mechanism. So I'll let Brian jump in there.
Yeah, so I think that was there's a lot of focus on the restriction now with primary care providers cannot enter into non-compete agreements. Those are prohibited moving forward. But another way that non-competes was defined under the new Indiana law is if you impose a financial penalty or repayment obligation for repayment of bonuses or similar payments like we were just talking about, and you base retention or repayment on that and the decision of whether they leave or not, that can be deemed a restrictive covenant, a non-competition restriction in and of itself, regardless of whether you included a non-compete otherwise in the agreement. And so what we're concerned is if that's now an invalid provision, is there a physician who's going to come back and say, I didn't have a non-compete, but I don't have to repay that to you because this was an unlawful restriction. We can work on language to address that and make sure that it's taken care of, and can work with clients on doing that. I think it's important that people just keep that in mind, though, as they're moving forward.
It's a complex question, but does that law make it harder to retain talent?
I think that law absolutely makes it harder for employers to retain physicians. What we've been talking about with our hospital providers is first of all, I guess in theory, you could look at it as a positive, because if someone else was subject to a restriction, then now they're free to not have restriction and you can incentivize them over. But that's maybe a little more common in a setting where there's more competition going on. In a rural setting, it's difficult. And when we talk about another common issue with rural providers is physicians are not going to cover they're not going to be profitable for the system when they first start. It's just not something that's realistic really on anybody, no matter, and that has nothing to do with their quality or whatnot. They're learning how to practice. They're getting ramped up in the community and getting people to know them. And if a rural provider becomes a feeding ground where they basically have a rotating door of providers who come in, learn the ropes, are not profitable, and the minute they turn profitable, they leave and go join a bigger system, they don't want to become the minor league system for the major league system. And so that you deal with that by finding people that you truly believe are going to be stuck with your community and have that stickiness to say, I belong here, I want to be here. But in addition, trying to design compensation in a way that allows for you to protect yourself. And we work on those issues as well. So it's definitely harder. There is not a lot from a regulatory perspective that is pro rural health right now. We're hopeful that the Rural Health Transformation Fund does some good, but overall it's a tough time to be alive, and we're here to try and help people figure that out.
And I completely agree. I think that the statutes and the way how Indiana has evolved with the non-compete restrictions and really lumped in this component that's tied to compensation really has changed the landscape, I think, from a recruiting perspective. And again, I think it puts pressure on employers, again, not only for losing providers, other systems, or not having the ability to retain folks. But I think it puts pressure on from a compensation perspective too. I think we're just going to continue to see those thresholds and those benchmarks to continue to rise because of the ability of a provider to go from one to the other without those restrictions in place.
So what does all of this mean when talking about non-employed physicians who work independently?
Yeah, so one of the other things we haven't touched on as much is we've been really focused on employed physicians, and that's really a key portion for our hospitals in the rural setting. But they often are not able to employ all their physicians, and they have service agreements with outside independent physicians or physician groups. We're even seeing physicians now who would historically been employed coming to hospitals and saying, I want to do this through my own separate company because they feel they can get better tax treatment on what they are paid. And that is increasingly common. That is really tricky because under those scenarios, the physicians don't always understand that they may not get benefits in that setting. In fact, they won't get benefits. You have to negotiate insurance, and it creates some risk for the provider, for the hospital. So if someone's listening and someone's asking you to do that, call your counsel. But in general, when we talk about employee compensation, Maggie mentioned the Stark Law and a kickback statute. There is more protection, generally speaking, under the Stark Law for employment relationships because there's more alignment there. There are far more, so I guess I should say the Stark Law does not require bad intent to be in violation of the Stark Law. The kickback statute is an intent-based statute, but the Stark Law, it doesn't matter if you had the best intentions in the world. And so we run into situations with clients where they've inadvertently violated the Stark Law because, for example, like Maggie said earlier, a contract expired and they continued to pay a physician. That is actually technically a Stark Law violation. And so when you have these contracts with independent third parties, it doesn't mean that these rules go away. In fact, in a lot of ways, it makes it more difficult. So we focused a lot on compensation design for employed physicians, but because rural health necessarily requires a village of outside providers to meet the need of the community, you've really got to look at those closely as well. And because a lot of times the bargaining power is off because the independent group knows that with absent their support, the hospital cannot provide the service. They're the only fill in the blank specialty group in town. They feel like they may have the leverage to get a better deal than necessarily, not only are they entitled to, but that they are legally entitled to. And so that's something to keep in mind. We've been really focused on employee compensation, but I just want to make sure that I note that because there's just as many, if not more, issues around that area as there are on employment sides.
Yeah, no, that's a great reminder, Brian. And I think just one thing to throw in there, I think a lot of times when we think about the Stark Law, we generally think of the employer paying, or the employer, the hospital, the health system, whoever paying a physician directly. And so to the extent these hospitals and health systems are contracting with other entities, I think sometimes people will immediately jump to say, oh, we're not paying a physician directly, so the Stark Law doesn't apply. And that's not always true. We have to go through a full analysis in those scenarios to determine whether it applies. So I think just as a quick reminder, it doesn't, just because you're not paying a physician directly, you're paying an entity, that's not going to necessarily save you from the strict liability of the Stark Law. And then the other thing to keep in mind too is, as Brian said, that there's better protections with paying an employed physician under the Stark Law and anti-kickback. As a baseline, Stark and anti-kickback require a writing for any type of arrangement, whereas with an employment arrangement under the bona fide employment exception, it's a little looser. A full writing isn't necessarily required to comply with or to meet that Stark Law exception. You still have to comply with the Stark Law regulations, which are fair market value, commercially reasonable, doesn't take into account the volume and value of referrals. But that writing piece is going to kick in automatically when you're contracting with an independent contractor or a physician group or any type of third-party entity there. You've got to have a writing. And so that's why it's so important when those contracts expire that we have something to fall back on, whether those are evergreen contracts or setting up reminders to make sure you have amendments in place.
Yeah. So I want to change gears just a little bit. And I want to talk about productivity-based compensation models. I know we touched on those a little bit before, but can you explain a little bit about what work relative value units are and how those function?
Sure. So this is really nerding out, but basically, if you think about someone charging you an hourly rate for what you do, like a lawyer, we have a flat hourly rate. It's the government's way of trying to try to prioritize and assign different values to the different levels of activity that a physician is doing. And so not every amount of time, not every 15 minutes in a physician's life is the same, depending on what you're doing, whether you're in surgery or you're doing a patient consult. So that is a weighting of the relative work value of what the physician is doing. And then that is taken and multiplied by, in a standard production-based model, a rate that is assigned to all of the different, but it's a flat rate. So really the RVU value differs. And then, and there's benchmarks for how many work RVUs a particular specialty a physician who's full-time should generate. And when Maggie talked about percentiles, a lot of the data comes out in 25th percentile, 50th, 75th, and 90th percentile. And then correspondingly, there's a rate that would be applied to that, $60 per RVU, $70 per RVU. And those will also be a lot of times viewed through the lens of the studies that come out, and there's different providers, MGMA, Sullivan Cotter, and they publish these studies. And so you get these benchmarks for both what work per RVU production is and the dollar production is. And so it matters, obviously, when you have a model that is, if a physician's only based on work RVUs, they're going to be very focused on that. If you get the behavior that you are incentivizing. And if you really focus on an RVU model, a physician's probably going to be very focused on their RVU production. If you start adding in quality measures, which is increasingly something when we look payers going to a value-based payment system, then you've got to look at how do I align those physicians from a value-based method, which may be quality and other things. And then hospitals are trying to say, how can I incentivize physicians to do those things too? Guess what? You have to take some of their compensation and move it out of the RVU bucket and put it into a quality bucket. And physicians don't like that because it's easier for them to understand, I work this much, I get paid Y. So that's part of the dance that we're doing, but that's the basics of what it is. If I try to make that as self-explanatory as possible, but it's not exactly the easiest thing to wrap your head around.
I wanted to know, why is this type of compensation model such a challenge for our rural hospitals in particular?
Yeah, I think you've got, first of all, when we talked about there may not be the level of patient base there to support the compensation level that they have to get to. I would say more often than not, when we come into a rural hospital that has not updated their physician compensation model, they're really more likely to be on a salary approach. And that can work and have alignment, but especially when you see physicians that are ramping up. And a lot of times, even if you're on a productivity model, the hospital is going to guarantee a certain base level of compensation the first couple of years. So it's a modified work RVU model, but a true salary is tricky because if the physician is not, if they're really, what's the motivation for them to go above and beyond other than they're committed to their craft? And especially as we see physicians who may be slowing down in their careers and trying to wind down, that alignment can get a little bit tricky. So that's something where we are always trying to find the right tool for the right situation based on what the hospitals have done. But I would say we're trying more to get physician compensation towards a work RVU model in a rural setting, less so than salary, but that's easier said than done.
And I think one additional component to tie back to our APPs who may be providing additional services and helping improve access in our rural health settings. Obviously, as we bring in APPs and they're performing more work, that's going to take away from the productivity of a physician at the end of the day. But just the way our billing regulations are set up, can't both bill for the same type of service or the same service that's being provided. So I think a lot of times what we're seeing is there's a little bit of reluctance sometimes of, okay, if we bring in APPs, is that going to reduce the productivity of the physicians and thus reduce their or lower their ability to be high earners under a productivity model? So what we've seen sometimes is when APPs are brought in, a physician, they will offer a physician a collaboration stipend. So basically, so long as the physician agrees to serve as the collaborating physician for this APP and perform the duties associated with being the collaborating physician, which in Indiana includes chart review, both for nurse practitioners and physician assistants, a little bit different there based on the practice and type of provider. But as long as that physician is truly performing those duties, it's a commercially reasonable way to make up that gap where if the physician is going to see a kind of a decrease in their productivity because the APP is picking up more of that work, they can maybe make up some of that gap with this collaboration incentive that they're offering. Again, we want to be sure, though, when we go about with these types of models, we want to be sure that the physician is actually performing these services. Again, these are services that are the chart review and the collaborative duties. Those are required by Indiana law. and actually are part of the licensure requirements for both nurse practitioners, physician assistants, and physicians. So we could run into some licensure trouble if they're not actually performing those duties appropriately. We want to be sure that they're not only doing it for those reasons, but then also, again, if we're going to pay somebody to do something, we want to be sure that they're actually performing the work and doing it. So I think, again, having a couple kind of safeguards in there as a health system or as a hospital to make sure that your physicians are complying with that if you're going to pay them for it, whether it's a quarterly check-in or some type of attestation type form that the parties are submitting to show that they are actually complying with those duties.
And lastly, I know we've circled around this somewhat during this whole conversation, but I do want to spend some time talking about why compliance is so important for our rural systems in particular. So in your opinion, why is that something that is especially important for our rural health systems to consider?
It's absolutely essential. Again, I think especially for our rural health providers, I think what our theme has been here is compensation is going to look different there. And I think when you start looking at things that look differently, we want to be sure that it makes sense. And we want to make sure we can justify that. So strong compliance programs can really help make sure that, one, we're documenting things appropriately, that there are appropriate safeguards and checks and balances in place, making sure that the right people are involved in making compensation decisions. I know we've talked a lot today about healthcare regulations, but again, as we start thinking about IRS regulations and things, we have to be sure that the right people are involved in making those decisions and setting the compensation. So I think having policies that can set out what are your goals in terms of physician compensation? Is it to reward productivity? Is it to reward productivity with a balance of quality metrics? And again, I think those quality metrics are key based on payers and programs involved with the government and things like that. What is your kind of philosophy overall in paying your providers? Is there a certain threshold that you start at? If somebody has just graduated, do you have a consistent approach to say, hey, for all of our new grads or for our physicians who maybe don't have a lot of experience, this is the baseline that we start at. We start with a guarantee or it's a base salary. I think going back to that production model, one thing to keep in mind as when we look at different specialties, sometimes that work RVU production model doesn't make sense for every specialty. And especially in our rural settings with OB providers, anesthesia providers, any type of shift-based specialty, it's that work RVU model doesn't always make the most sense. So really, again, setting out in your policies, what's your philosophy for those different types of specialties? And then again, including what are your checks and balances? Do you perform an annual audit of all physician compensation? And if you have folks they're teetering at a certain kind of level of compensation, what do you do in that scenario? If you've got somebody who benchmarks above the 100th percentile, what's your process for that? So making sure your policy kind of sets that out as well. And then the other thing we've talked a little bit too about is having fair market value evaluation firms and external evaluators in your back pocket to be resources to help you in those scenarios. Getting those fair market value opinions when we do have compensation that maybe doesn't meet our internal gut check of what we consider fair market value. What is the trigger that we say, okay, now we need to go out and we need to get this opinion and we need to get an expert to tell us that, yes, this is still fair market value and commercially reasonable based on all of these factors. I always like to say, let the numbers guys get involved and let them crunch the numbers and figure all of that out. So I think having a policy that sets that out, I always say too, if your hospital doesn't have a strong policy right now, start small. Don't go out and try to completely revamp everything in a month and 6 months. Start small. Start with what's your audit process going to be? Because again, as part of that process, you're going to be looking for your high earners, your low producers, and then also making sure that the arrangements all still make sense.
Generally speaking, how often do you think a compensation audit or assessment should happen?
I would say generally on an annual basis. Again, kind of tying that to your annual earnings. You can pull W-2 earnings for employed physicians and say, here's everything they earned in 2025. We're going to review that. We're going to run it. We're going to compare it against the specialty benchmarks and then go from there and see what gives you heartburn, what meets your internal triggers. And the other thing is, as we think about the policies too, if you're going to have this type of a process to go through an audit, you have to kind of think about what's your plan after the audit. So when you go through that process and somebody is identified as a high earner and a low producer, and maybe that doesn't justify that compensation anymore, what's your process now? Again, goes back to Brian's point of that's when those hard conversations have to happen. How are you going to make adjustments to that compensation? Do you have the ability to make adjustments per a contract, per the employment agreement language? So kind of thinking about how all of those things tie together, and not just having a process, but also having a plan for after the process. If that's enough procedural words in one sentence for you.
Last but not least, I did want to talk about the future. So are there any particular compliance trends that rural health leaders should be watching out for right now, either positively or negatively?
I would just say that, first of all, you're not alone in this. There was actually a study that came out. I think the National Rural Health Association helped advance it, but said that nearly half of rural hospitals are struggling with outdated compensation practices that need attention. And so I think there's removing a stigma behind what you're trying to do and that you have a problem, especially to say, if we change this, it's going to make it seem like we're doing something wrong before. That mentality is just got to go out the window. I do think there's more focus on this. I think there's continued focus from the government. CMS always comes out and says what return on investment they get for the money they invest in compliance and the regulators. And it's like a $4 to $1 return on their money for every dollar they spend tracking down people. So they're going to keep looking. And I think for a long time, rural providers thought that they were somewhat immune from the scrutiny of the government. I think they've now seen over the last however many years that there's a lot of focus on rural health. And I think they've got to know that the government's not just going after the big players anymore. So I think what I would say is there is more of a culture of compliance around looking at these issues and that people need to pay more attention to them. I don't know that I would say there's a trend in a bad way. I think it's good that people are talking about it, that we're talking about this on a podcast for your listeners. I think that it's really a positive momentum, but that doesn't diminish the fact that it's just a tough time to figure out the right way to balance it. And every organization's different. And that's where we feel like we can come in and offer some perspective because we've worked with so many different hospitals and health systems to be able to say, here are your options. Let's find a path that works for you. It's scary. It's a big implementation. It requires a lot of good communication and consensus building, but there is a way. And I think that people are seeing that.
Yeah, I think that's spot on. I agree. I don't know that there's a specific trend in one way or the other. Again, it can be overwhelming and it can feel daunting, but I think the concept of start small, start where you can, and start thinking about how you can get these programs up and going, whether it's an audit or just maybe it's just pulling all of your active contracts or all of your contracts to say, how are we paying everybody? Are we still paying? Should we be? Should we not? Just moving in that direction toward what are the initial steps you can take towards compliance and getting these arrangements in check.
Maggie, Brian, thank you both so much for being here today and sharing your expertise with me. I learned a lot, and I know our listeners will too. Thank you for listening to this episode of Rural Health Everywhere, and a special thanks to both of our guests, Brian Heaton and Maggie Little from Krieg DeVault, LLP. If you want to listen to more conversations about rural health in Indiana, please subscribe to this podcast. If you want more information about the Indiana Rural Health Association and the programs behind this podcast, visit our website at indianaruralhealth.org. And lastly, thank you to our members and business partners. You make this program and what we do possible. I'm excited to talk to all of you